welcome to the deep dive. Today we're tackling something a bit different, upper extremity arterial disease. We often think about blocked arteries in the legs, but the arms, well, that's a whole other story,
Yeah.
often more complex.
It really is. Unlike the legs where atherosclerosis is usually the prime suspect, the upper limbs, they've got a much wider range of potential causes.
Like what sort of things are we talking about?
Oh, things like autoimmune diseases, Takayasu's, Giant Cell Arteritis, mechanical issues, Thoracic Outlet Syndrome, emboli traveling from elsewhere.
Hmm.
Also things like hypothenar hammer syndrome, and yes, atherosclerosis can still play a role too. It's quite a mix.
Okay, so with all those different causes, I'm guessing the treatments aren't straightforward either, not just one fix.
Exactly. Treatment really has to be tailored. It could be medical management, maybe surgery. Often it's a combination. It really hinges on figuring out why the blockage is happening.
Right. Now, even though it's complex, this isn't as common as leg problems, is it?
No, thankfully not. Upper extremity arterial occlusive disease accounts for less than 5% of all limb ischemia cases. It's relatively uncommon.
And where do these problems usually show up? Is it the big arteries near the shoulder or further down?
Interestingly, the most common area is actually distal, the palmar and digital arteries, so in the hand and fingers. The larger vessels, proximal to the wrist, that's actually less frequent, under 10% of cases. Might be a bit counterintuitive for some.
Yeah, it is a bit surprising. So if we're talking about sudden blockages, like a clot traveling in embolus, where do those usually come from when they hit the arm?
The vast majority, maybe 75%, they originate in the heart. And the most common place they get stuck is the brachial artery that's in the upper arm, about 60% of the time.
The brachial.
Yeah, followed by the axillary artery, closer to the shoulder, maybe 26%. Clots forming right there in the arm artery, in situ thrombosis, that's much rarer, only about 5%.
Got it. So just to be clear, for everyone listening, today we're really focusing on revascularization, getting blood flow back for both acute and chronic ischemia, specifically in the axillary, brachial, radial, ulnar, and palmar arteries.
Right.
We're setting aside things like Raynaud's, thoracic outlet syndrome, the big brachiocephalic artery issues, and those specific arteritis conditions like Takayasu's. They're really topics for another day.
Precisely. We're zeroing in on blockages within the main pipeline supplying the arm and hand itself.
Okay, so let's dive into the options. Someone gets this diagnosis.
Mm-hmm.
What's the first line of thinking, treatment-wise?
Well, for a decent chunk of patients, maybe somewhere between 9 and 30%, conservative therapy is actually the way to go initially.
Right, conservative.
Usually because they have other major health problems, comorbidities, or maybe their symptoms are just quite minimal.
And what does conservative actually mean here? It's not just waiting and seeing, is it?
Oh, no, not at all. For acute or subacute ischemia, anticoagulation blood thinners is key. Then there are other things, adjunct therapies like calcium channel blockers, topical nitrates, phosphodiesterase inhibitors, though their success can be a bit variable.
And lifestyle stuff too, I assume.
Absolutely critical. Stop smoking, that's number one. Optimize heart function, avoid drugs that constrict vessels, cut back on caffeine, stay out of the cold, keep the arm warm. It all helps.
Sounds pretty comprehensive for those not needing immediate intervention. But how well does this conservative approach actually work long-term?
That's the important question. While it's right for some, we have to look at the older data. Studies from back in the 60s, 70s, 80s, they showed significant rates of permanent disability or poor function in patients managed conservatively. So while it has its place for patients with a reasonable life expectancy, the general feeling is that restoring blood flow directly is usually the better path to prevent long-term issues.
That's a really crucial point. Conservative management isn't always the end of the story.
No, often it isn't.
So, moving towards restoring flow, endovascular techniques are getting more common everywhere else, right? Stents, angioplasty.
They are, absolutely. Technology's advanced hugely. In the lower extremities, percutaneous revascularization is really dominant now.
But has that same shift happened in the upper extremity?
It really hasn't, not to the same extent.
Why do you think that is?
Well, it could be several things. Maybe interventions are just needed less often in the arms, or perhaps it's the diverse causes we talked about, not always simple plaque. Or honestly, sometimes open surgery in the arm is relatively straightforward and works very well.
So the old ways sometimes stick around for good reason.
It seems so in this area. There was a Japanese study on the subclavian artery, that's a bigger one, more proximal, showing good results with angioplasty and stenting. But the details on exactly which part of the artery were a bit unclear.
Okay, but for the arteries further down, axillary, brachial, radial, ulnar,
For those, most centers still lean towards traditional surgical bypass or embolectomy, removing the clot surgically.
So endovascular is more the exception there.
Generally, yes, you see case reports, emergency covered stents for axillary trauma, maybe angioplasty for radiation damage, brachial atherectomy, radial stenting for really bad finger gangrene. But these are usually small numbers,
Yeah.
limited follow-up, not the standard approach yet.
Right. Okay, let's talk surgery then. How do surgeons actually get access to these arteries? It sounds like they're tucked away.
They can be. The specific techniques are quite detailed, but we can cover the basics. Let's start with the axillary artery, up near the shoulder.
Okay. How's that done?
Patients usually on their back, arm out to the side or across the chest. The cut is typically just below the middle of the collarbone, the clavicle, maybe transverse or sometimes oblique along the edge of the pec major muscle.
Do you have to cut through muscle?
Often, yes. The pectoralis major fibers might need dividing. Then you go through the clavipectoral fascia underneath. The artery is usually just above the axillary vein. The really critical part here is being careful around the brachial plexus, that big bundle of nerves. You have to dissect very carefully to avoid damaging them.
Sounds delicate. What about the brachial artery further down the arm?
Depends where you need to be. For the mid or distal part, usually an incision on the inner side of the upper arm over the basipital groove. Got to watch out for the basilic vein and some small sensory nerves near the surface. The median nerve is often right there, superficial, so you gently move it aside to see the artery. And you might divide some small crossing veins to protect the ulnar nerve, which runs a bit deeper behind the artery there.
And down near the elbow crease, the antecubital fossa.
Right, for the very end of the brachial and where it splits into the radial and ulnar arteries, that's the spot. Often a curved incision, like a lazy S shape, is good there. Gives good exposure, less risk of scar contracture across the joint than a straight cut, or maybe a vertical incision just below the crease for the very end.
Still need to watch out for veins.
Definitely, especially the median antecubital vein, might need it for a patch later. You incise the bicipital fascia, and the artery is usually sitting between the biceps tendon laterally and the median nerve medially. You dissect down and you'll see the radial artery kind of continuing straight down, while the ulnar takes a dive medially under some forearm muscles.
Okay, forearm now. The radial artery.
The radial artery runs sort of obliquely down the thumb side of the forearm. From the elbow towards the wrist bone, the radial styloid. Mid-forearm, it's nestled between the brachioradialis muscle laterally and the flexor carpi radialis medially.
So how do you get to it?
Usually a longitudinal cut on the outer aspect of the forearm. Separate the muscles carefully. It's relatively superficial there. Big thing to watch for is the superficial branch of the radial nerve. It runs very close by, and injury can cause numbness or tingling on the back of the hand and thumb.
Ouch. Okay, and the ulnar artery on the other side.
The ulnar runs down the pinky side from near the medial epicondyle, the bony bump on the inside of your elbow, towards the pisiform bone at the wrist. In the mid-forearm, it's deeper than the radial, under fascia, between the flexor digitorum superficialis and the flexor carpi ulnaris muscles.
Nerves nearby there too.
Yes, the ulnar nerve itself runs right alongside the artery for much of its course, on the ulnar side. Very important to identify and protect it. At the wrist, the artery is just lateral to the flexor carpi ulnaris tendon, that prominent tendon on the inner wrist. A vertical incision just radial to that tendon works well. It's a bit deeper than the radial at the wrist, but accessible. Need to preserve the palmar cutaneous branches of the ulnar nerve too.
You mentioned interosseous arteries earlier. They sound less common to work on.
They are. They're the smallest and deepest forearm vessels, sort of like the peroneal artery in the leg, supplying deep muscles. You find the common interosseous by following the ulnar artery down, looking for a branch going deep between the radius and ulna. It splits into anterior and posterior.
How do you access those?
The anterior interosseous, usually through the same approach as the mid-ulnar artery, separating the flexor muscles. The posterior is harder, needs an incision on the back of the forearm along the radius. It's smaller, less often used for bypass.
And finally, down in the hand itself, the palmar arteries.
The hand has those arches, superficial and deep, formed by branches of both radial and ulnar arteries, like in the foot. Exposing the superficial arch is usually pretty straightforward. The deep arch is, well, deep. Requires careful retraction of nerves and tendons.
Where do you make the cuts?
For the distal radial, you can use the forearm approach extended down, or a cut right in the anatomical snuff box, that little depression on the thumb side of the wrist. For the distal ulnar and the start of the superficial arch, A curved incision along the base of the little finger, the hypothenar eminence, the middle part of the superficial arch. Incisions along the palm creases work best.
Okay, great overview of the getting there. Now, for bypasses, what do you use for the graft itself?
The best choice, really the gold standard, is autogenous vein, meaning the patient's own vein.
Which vein?
Usually the great saphenous vein from the leg. It's long, good size. Sometimes the cephalic vein from the arm itself can be used, occasionally even left in place in situ bypass. One thing to remember, though, the more joints the bypass has to cross, generally the lower the long-term patency rate. More stress, more movement.
Makes sense. So once you've taken the vein out, how do you prepare it?
Patient gets heparin first, blood thinner. Then the vein is carefully handled. Side branches are tied off. It's gently distended, inflated a bit, with a special solution, usually dextrin, heparin, and paparin to prevent spasm.
And which way does it go in?
It can be reversed, so the valves inside don't block flow, or it can be put in non-reversed, orthograde. If it's orthograde, you have to break the valves, usually with an instrument called a Mills valvulotome.
What about artificial grafts?
They just don't tend to work as well long-term in the upper extremity compared to veins, so we avoid them if there's a good vein available. Autogenous tissue is still king here.
And tunneling the graft, getting it from point A to point B.
Right, that's important too. If the bypass starts from the axillary artery, anatomical tunneling is often preferred following the natural path of the vessels. Less prone to kinking. Subcutaneous, just under the skin, is another option, but maybe more vulnerable to compression if the arm is moved forcefully. Need to leave some slack. Redundancy. There's also a retrohumeral route for bypasses starting above the collarbone, going sort of behind the shoulder and around the humerus.
What if the bypass starts lower down, from the brachial artery?
Then subcutaneous tunneling is common. Easy to examine the graft later, easy for ultrasound surveillance, avoids messing around in your forearm nerves, or if the arm veins are good, an in situ bypass is an option.
And tunneling down to the wrist or hand?
For the radial side, usually subcutaneous over the thumb tendons towards the snuff box, maybe ending between the thumb and index finger to connect to the deep arch or a digital vessel. For the ulnar side, it's often more direct. Subcutaneous, superficial to the wrist ligaments, just lateral to the pisiform bone, connecting to the superficial palmar arch.
Okay, let's switch gears slightly. Transbrachial embolectomy, removing a clot. When is that the go-to?
That's mainly for acute sudden blockages caused by an embolus, a key thing. If imaging shows the blockages in the distal brachial artery near the elbow, you really need to expose the origins of both the radial and ulnar arteries.
Why expose both?
Because if you just blindly pass a catheter down the brachial, it tends to want to go into the radial artery, which is often the straighter shot. You might clear the radial, but miss clot in the ulnar, which could be crucial for hand perfusion. Or the catheter might even go into the common interosseous, so direct visualization is safer.
Makes sense. So what's the technique once you've exposed them?
Usually make a transverse cut arteriotomy in the brachial artery just above the split. You remove any visible clot, often found right at the bifurcation. This can often be done under local anesthetic with monitoring.
Any risks with the catheter?
Yes, passing it proximally, back up the arm, needs caution. Risk of dislodging plaque that could go up to the brain via the vertebral artery. If concerned, angiography might be needed. Then you gently pass a small balloon catheter, maybe a 2 or 3 French, down into the radial and then the ulnar artery separately to retrieve distal clots.
How do you close the artery?
If the artery is a good size, you can often close the arteriotomy directly with fine stitches. If there's any doubt it might narrow the artery, cause stenosis, then a patch is better. Usually a small piece of vein taken from nearby.
And after closing, how do you check if it worked?
Right away, on the table, use a handheld Doppler to listen for good flow signals in both the radial and ulnar arteries at the wrist. Some surgeons also routinely do completion angiography.
Angiography, right there in the OR.
Yeah. Inject contrast dye and take x-rays. It shows any leftover clot or maybe underlying chronic blockages further down you didn't know about. It's especially recommended if the hand still looks ischemic after the embolectomy, or if you pulled out a lot of clot initially. There was a study, Zarka et al., that showed doing angiography led to lower reocclusion rates, probably because it helps ensure a more thorough clot removal.
So better confirmation of success.
Exactly. And if you suspect the problem actually started higher up an inflow lesion in the subclavian or axillary, you might do intraoperative arteriography then too, maybe via the femoral artery or brachial access higher up.
Okay, surgery's done. What's the follow-up like?
Post-op surveillance is important. Non-invasive tests like pulse volume recordings or segmental pressures give an overall picture. Duplex ultrasound is key for checking bypass grafts, making sure they're open, and catching any early narrowing stenosis, especially in vein grafts.
How well do these repairs hold up long term?
We actually have less really long-term data for upper extremity compared to lower, but midterm results look pretty good. One study, Roddy et al., showed 90% primary patency at 1 year for brachial bypass. Another, Spinelli et al., found 83% primary patency at around 34 months for chronic ischemia bypasses.
What about blood thinners after surgery? Anticoagulation.
It's generally essential after an embolectomy to prevent more clots, but for bypass surgery. Not routinely needed unless there's a specific reason, like a known clotting disorder or maybe atrial fibrillation needing treatment anyway.
You mentioned clots coming back, recurrent embolization.
Yes, that's a real risk after embolectomy, especially if the underlying source isn't addressed and the patient isn't anticoagulated.
Oh.
It happens in maybe a third of cases without anticoagulation. Even with warfarin, patients with persistent atrial fibrillation can still throw clots.
So if the source wasn't obvious, like AFib?
Then further investigation is usually warranted if comprehensive imaging wasn't done around the time of surgery. Formal arteriography, CTA, MRA to look for arterial sources. If nothing's found there, then an echocardiogram to check the heart is usually the next step. Need to find that source.
Right, treat the cause, not just the symptom. Are there other therapies sometimes tried besides surgery or endovascular?
Well, sympathectomy interrupting sympathetic nerves to improve flow has had isolated reports of success, but generally outcomes aren't great in most centers.
What about clot-busting drugs? Thrombolysis.
It's been used for acute axillary or brachial blockages. Some reports show reasonable outcomes, but a large review found it only worked in just over half the patients, and many still needed surgery afterwards to get the rest of the clot out. It's also been tried for acute finger ischemia, blockages below the wrist, but results there are pretty mixed, both anatomically and functionally.
Okay, let's shift focus now to trauma. You said that's a fairly common cause, too.
Yes, definitely. Both iatrogenic, caused by medical procedures, and non-iatrogenic, like accidents or violence.
Let's start with iatrogenic. What are the common culprits?
Brachial artery injury after cardiac catheterization is quite common. Either a pseudoaneurysm, a contained leak, or a complete blockage and occlusion.
How does that present?
Could be a pulsating lump where the catheter went in, signs of poor flow downstream in the hand, or even nerve problems like tingling if the median nerve gets compressed by the hematoma. Diagnosis is usually straightforward with duplex ultrasound.
And treatment?
Depends. For a pseudoaneurysm without nerve issues, sometimes percutaneous thrombin injection works well. Inject clot-forming medicine into it. If there are nerve symptoms or if thrombin fails, then open surgical repair is needed, usually under local anesthetic. If the artery is actually occluded, you might need a bypass segment using vein. If caught early, maybe just balloon embolectomy can clear the thrombus. Later recognition often means a formal interposition graft.
What about the radial artery? It's used for access a lot now.
It is, and it's the second most common site for iatrogenic injury. Radial artery occlusion after cannulation happens, maybe even up to 25% in some older series with monitoring lines. But clinically significant hand ischemia is rare because the ulnar artery usually provides enough collateral flow via the palmar arches.
So what do you do if the radial artery clots off after procedure?
Usually just observations after the catheter's out. Most improve on their own. Heparin during the procedure helps, but isn't mandatory afterwards just for the occlusion itself. Only in very rare cases with severe ischemia would you consider a short bypass graft. Even with bigger sheaths used now for cardiac cath via the wrist, symptomatic occlusion rates for radial or ulnar are pretty low, around 5%, and mostly asymptomatic.
Okay, now non-iatrogenic trauma accidents, violence.
Right. Can be blunt or penetrating, both common. Military injuries often add another layer of complexity.
Let's take penetrating injuries first. Stabbings, gunshots.
Usually pretty obvious there's an injury. Repairing the artery itself might not be the hardest part. Getting control of the bleeding proximally can be the real challenge. Depending on where it is, subclavian might need a chest incision or endoballoon. Axillary needs subclavian exposure above the clavicle. Brachial needs an upper arm incision. Tourniquets can help temporarily.
What if it's just the radial or ulnar artery hit?
If the hand looks fine, good perfusion, you could ligate it, tie it off. But repair, often with a bit of local vein, is generally preferred, especially in younger people. The debate on ligate versus repair for an isolated forearm injury in a pink hand still goes on.
What if the injury isn't obvious right away?
That's a concern. Delayed pseudoaneurysms or AV fistulas can form. So have a low threshold for imaging duplex or CTA after any penetrating wound near a major artery. Gunshots especially, even if they look okay initially, the thermal injury can cause delayed problems, so repeat imaging might be wise. Glass injuries to the forearm can also cause hidden artery damage, leading to delayed bleeding or compartment syndrome. Image them early.
And if you find something later,
Address it promptly. If you find an asymptomatic occlusion later, you might observe or reconstruct depending on the situation, similar to leg injuries.
okay, what about blunt trauma? Car accidents, falls.
These can be tricky. Harder to diagnose and pinpoint the injury. Often associated with nerve damage and fractures, so a good neuroexam is vital. Pre-op imaging, like arteriography or CTA, is often really helpful here. Bleeding isn't usually the main issue like in penetrating trauma, it's more about fixing the damaged segment. One thing with severe blunt trauma is you often get significant vein injury too, which can lead to venous hypertension and bad swelling after you fix the artery. Repairing the vein might help, but it's controversial.
And that specific pediatric injury, supracondylar fractures.
Ah, yes, the elbow fracture in kids.
Right.
The controversy is mainly around type 3 fractures where the radial pulse disappears after the injury, but the hand still looks pink and viable. The worry is long-term ischemia leading to Volkmann's contracture, a permanent muscle death and deformity. The brachial artery can get pinched, torn, or thrombosed.
So what's the standard approach?
First step is always orthopedic reduction, getting the bones lined up. Then reassess the circulation. If the pulse comes back, great, just observe closely. If the pulse is gone and the hand looks ischemic white, pale, cold, then surgical exploration of the artery is needed.
And the controversial part.
Is when the pulse is gone, but the hand looks okay, pink and warm. Some say observe carefully, serial exams. Others say be aggressive, explore and repair the artery anyway, direct repair, patch, or bypass. You have to be super careful manipulating kids' arteries, though. They spasm easily. It's fortunately not a common scenario for severe ischemia. Extra imaging usually doesn't change this initial decision-making based on the clinical exam after reduction.
Complex situations. Okay, wrapping up the potential issues. What are the major complications across the board with these upper extremity arterial surgeries?
Nerve injury is a big one. Brachial plexus, median nerve, ulnar nerve, they're all close by, usually due to traction during surgery. Gentle handling and minimal cautery near nerves is key. Graft thrombosis, the bypass clotting off, seems more common in female smokers, and with longer grafts crossing joints. Missing an inflow lesion like a blockage in the subclavian artery, causing the arm symptoms during just a brachial embolectomy, won't fix that. Arterial spasm, especially during embolectomy in younger people with healthier arteries, it's a diagnosis of exclusion after you're sure the clot is out. Treat with vasodilators, warm saline, patience.
And anticoagulation needs careful thought, as we discussed.
Right. Needed if the embolic source persists, usually not routinely after bypass unless there's another reason.
What about compartment syndrome? We hear about that in the legs.
It can happen in the arm too, though it's rarer. Reperfusion after significant acute ischemia can cause swelling in those tight forearm compartments.
Same treatment.
Yes, decompressive fasciotomy. Opening up the compartments, usually volar and dorsal aspects of the forearm. Severe cases might need extension into the hand, releasing the carpal tunnel too.
Well, this has been incredibly thorough. We've covered so much ground on upper extremity arterial disease. What are the absolute main things you want our listeners to take away?
I think the biggest things are, first, recognizing the complexity. It's not just one disease. The causes are really diverse, and that dictates everything, the workup, the treatment, the type of reconstruction. Second, a careful workup and exam are just crucial to pin down that underlying cause. And third, often surgical bypass is necessary, sometimes right down to the hand. Those hand bypasses, while delicate, are actually quite analogous to foot bypasses. Endovascular options in the forearm are still more selective right now for sicker patients, palliation, that sort of thing.
So the key, really, is understanding that diverse landscape of causes and tailoring the approach. You, our listener, hopefully now have a much clearer picture of just how intricate blood flow issues in the arm can be, from why they happen to how we fix them. Definitely more complex than many might assume.
It certainly is.
And that complexity makes you wonder, doesn't it? Thinking about this tangled web in the upper limb. What other medical problems that seem localized on the surface might actually have such a surprisingly broad range of hidden causes and potential solutions? Something to think about. Thanks for joining us on this deep dive.